Good morning, everybody. The today's topic is three topics. One is consolidation, fibrosis, lung fibrosis, and collapse. I want to tell you on the outset that clinically you cannot diagnose these three conditions in one patient. Yes, one can see on the CT scan only. Even XHS is not good for it. So we will discuss one by one. Okay, because the clinically you cannot in examination you can say case में fibrosis भी है, consolidation भी है, और collapse भी है. So we will discuss one by one. First, consolidation. A patient of 8 years old, gentleman, presented with the complaints of fever, chest pain, and cough for the last 5 days. The fever was high grade. It started with the sudden onset and associated with the chills and rigors. The fever was associated with the chest pain, which was limited to the right side of the chest. It was dull-like, but however, it used to increase on coughing and deep inspiration. The cough was productive, so was bringing small amount of sputum. On further inquiry, the patient revealed that he has no convulsion, loss of consciousness, aspiration, or catheterization. Why I'm asking this question? We are asking this question because most of the time the pneumonia occurs due to aspiration or bloodborne. Bloodborne means due to catheterizations, DNC, or any other operation. There's loss of consciousness, convulsion. The patient have the aspiration. So we have to rule out these things. Okay. In the past, patient has not has this such a disease, and no epilepsy again. Epilepsy. Why I'm asking epilepsy? Because during fit, the patient lose consciousness and their chance of aspiration. The same, the no history of surgical operation. That patient was not prone to the aspiration. General anesthesia. The family history was not contributed. Personal history, he was non-smoker, and occasionally he used alcohol, otherwise he was not alcoholic. On physical examination, the patient was found to be conscious and oriented in time and space. However, the temperature was 102.2 centigrade. PP was okay. Respirator was high, little high on the higher side, but not very high, 20 per minute. Pulse rate okay. Saturation was 96%. There's no clubbing, no sinus, no jaundice, no lymph nodes were palpable. Now start with the chest examination. I always told you that chest examination in the last lecture also, the chest examination should be sequentially: inspection, palpation, percussion, auscultation. Don't jump direct to the auscultation. When you are asked in the examination, इसमें क्या finding है, तब सीधा ही auscultation की बात करते हो. Start with inspection, palpation, percussion, and auscultation. I've already told you, I think last time also, you should describe these findings due to these thoracic areas. These are the infraclavicular, that's below the clavicle, memory, memory region, suprascapular on the back, between the middle edge of the scapula and mid-spinal line, subdivided further into superior and inferior, subscapular immediately below basal, covering the basal part of the lung below the subscapular area, axillary upper part, infraaxillary lower part of the axilla. These areas are nothing like that इस space से लेके space है, इस rib से लेके rib है. These are the arbitrary lines. These are divided. That's only to show that where you are moving, you are when you are describing your findings. Okay. So we will describe the finding according to these. Last time also I told you there is nothing like supraclavicular. Many times people tell you supraclavicular है, supraclavicular के ऊपर लंग होता ही नहीं है. So we should not describe. जो होता है छोटा सा होता है, that is just below the sternocleidoid muscle. So you cannot examine that. This is to describe you that you can see. This is the front. Then the front there is most the upper lobes, left upper lobe, and middle lobe, and this is the part of the lingular is part of the upper lobe, and on the back, suprascapular the upper lobes and the lower lobes. So you can see there is in front there is no lower lobe. Why I'm asking sometime to finding in the memory region और बता देते हो कि right lower lobe है. Front पे right lower lobe होती ही नहीं. Okay. But in axilla they all meet together. Upper lobe, middle lobe, lower lobe, upper lobe, and this on the left side. So ये गलती करते हो एग्जाम में. That's why I'm telling you. On inspection, the chest shape seems to be normal. There's no abnormality like kyphoscoliosis, scoliosis, rib deformity, soft tissue swelling, or prominent veins. The respiration was thoracoabdominal. However, there was some subtle finding was that the right chest movement seems to be less. The tracheal position could not be decided. Apex beat also could not be located. On palpation, the position of the trachea was found to be central. Apex beats again could not be localized. Thoracic expansion was 6 centimeters. However, thoracic movement, chest movement, reduced on the right hemithorax. The vocal parameters, last time also, I think in one of the lecture I told you, there's expansion. Okay. The expansion and movements are two separate things. These are not synonymous. Expansion you are measure with the tape at the level of the nipple in the male and below the breast in the women. Okay, and this is generally for some not that medical fitness purpose. Okay, which is mostly on the army or in the police. So these are not synonymous. Expansion is different, movement is different. I want to stress again. Okay. The vocal parameters are increased in the infraaxillary, subscapular, and basal parts of the right chest. The left chest was normal on palpation. Percussion. The note was dull on the infraaxillary same areas which I have told you. The vocal parameters, subscapular, and basal parts of the right chest. Tidal percussion. I told you in the when I took a long lecture what is the tidal percussion. It could not be possible due to the dullness of the right basal area. Left chest was again examination was percussion was normal. On auscultation, The breath sound and vocal resonance increase in the same area, which I told you earlier, earlier slides, infraxillary, subscapular, and basal areas on the right chest. However, there is bronchial breathing, bronchophony, and whispering fatigue was present in the same areas, infraxillary, subscapular, and basal areas of the right chest. There are also associated, there's a fine crepitation found in the same areas where the bronchial breathing was found. On a proper examination was done, there was evidence of pleural present on the right chest at the back in small part, not the all over. Small part, small patch was in the pleural, found one. Pleural bit result. That left chest examination was normal. Left side. Other system, the CVS and abdomen was normal. And sinus, there is no meningism and meningitis. Why I am citing meningism, meningitis? Because in pneumonia consolidation, meningism or meningitis can happen. So you should rule out while presenting your case. So we have found on examination, this is the triad. And there's a bronchial breathing, bronchophony, and whispering pathology. It is known as triad. That means it is evidence of the consolidation. When I discussed with the collapse, there can also be this triad present. That does not mean that will be the consolidation. That will discuss collapse. So again, the last time also I told you how to present the right diagnosis, because you should know what you have to find. You have to find pathology. Then that pathology is which anatomical part is involved. Many times जब एग्जामिनेशन होता है तो एग्जामिनर सीधा पूछते हैं भी क्या डायग्नोसिस है सर टीबी टीबी किस चीज की लंग की कौन से लंग की राइट लंग की ये कोई डायग्नोसिस नहीं होता है ठीक है सो as you will see in this case, this is the consolidation, that is the pathology, right lower lobe. But there was evidence of pleuritis also. Some problem is there, but there was no evidence of the pleural diffusion. Probably because the short history was there, it is pyogenic bacteria, most probably. Okay, of course, we have to find the on the investigation also. So, the pathology, anatomy, and there is evidence of pleural also due to the pyogenic bacteria. So, pathology, anatomy, etiology. Because if you know these three things, फिर आप हिस्ट्री भी वैसे ही लोगे, एग्जामिनेशन भी वैसे करोगे कि मेरे को जो तीन चीजें देखनी है. This was the XHS was in the same case. You can see the consolidation on the right lower lobe. It is further elaborated. You can see the right lower lobe. Pneumogram was done. Consolidation, it is to be done. It was showing neutrophilia, 85%. The kidney function, that BGN or everything were normal. I will tell you why this is important later on. And LFT was normal. Liver function test was normal. The gram stain of the sputum was done. It was positive for the diplococci. The sputum was sent for consistency, streptom pneumonia. And blood culture also sent. Blood are always sent in pneumonia, blood culture. Many times the sputum is coming just from the throat. But if it is present, the bacteria is present in the blood culture, it's very, very important. Very good information. Okay. The treatment depends upon how the pneumonic consolidation is severe. If there is a confusion, blood urea is high, respirator more than 30, there is hypoxemia, hypotension, BP less than 90, systolic, diastolic 60, and extreme of the age. But in this patient, confusion bhi nahi, uremia, respiratory it was 20 only. This was saturation was 96%, no hypoxemia. BP was okay, and age was also okay. So we will not say this is a severe type of pneumonia because the treatment differs with the severe, and if it is not severe, we can treat in the outpatient also. This is the some people are making the scoring also. The confusion 1 score, blood urea, respiratory rate, BP, age, and 0 to 1, outpatient, inpatient versus observation, and mortality is less in the same which I told you in the previous slide. The treatment is a not severe, we can outpatient. Not patient does not need admission in the hospital. And you will always start with empiric therapy, which is mostly successful. And in patient with no comorbidity, no therapy with macrolides such as azithromycin, alkylate are the first choice. Alternative, you can add if the patient is not tolerating it. You can give the fluorochloroquines like levofloxacin and other. Okay. If the patient is severe, the recommended therapy is neurofluoroquinolones alone. I will advise you, I always give the combination of different generations, at least 3 antibiotics. Well, pneumonia is otherwise is very notorious. In the old age, some people say this is the way to the death in very old people, the pneumonia. When you are given the patient of pneumonic consultation in Baiwa, in that you are generally asked, what is a community acquired pneumonia? Community acquired pneumonia is a lung infection that develops in people outside the hospital. It can be due to bacteria, virus, and fungi. Okay, outside the hospital, it's a community acquired pneumonia. In Viva, during the otherwise also, in the final Viva, grand Viva, you are generally asked if you are given this case. Then they ask what are the hospital acquired pneumonia? Hospital acquired pneumonia is also known as nosocomial pneumonia, refers to any pneumonia contracted by a patient in a hospital is 40 to 70 hours after being. It is usually caused by bacterial infection rather than a virus. So, CAP, HAP. One again is VAP, ventilator associated pneumonia. Ventilator associated pneumonia आपको तो नहीं देंगे, but you should know it. Ventilator associated pneumonia is a type of lung infection that occurs in people who are on mechanical ventilation. Naturally, it affects the critical patients, which are the intensive care unit. Along with this, the diagnosis of ventilator associated pneumonia is made if there is a presence of new infiltrate while the patient was admitted in the hospital. That infiltrate was not there. Now it is present. It's a new filtrate. And if the temperature is more than 38 or hypothermia, it is not less than 36. Both are not good. That if it is a hypothermia, that means the patient defense mechanism is poor. Okay. And blood count is more than 12,000, and there is a pruritic secretion. So this is how you diagnose. If two or all these are present, that me will diagnose the patient who is on the ventilator, which was earlier X-ray was normal and was not febrile, but there is no temperature, there is no fever. So that patient has developed the ventilator associated pneumonia, VAP. Okay. That is the first case, consolidation. Now we will start with the lung fibrosis. Okay. You can write down in your book, notebook, that any question you want to ask. You can just have a rest for 2 minutes. Then we will start the next. Okay. Now you are ready for the next case. The history was, the patient was 56 years old male. Occupationally, he was doing tailoring. He came with presented with the chief complaints of breathlessness of 2 years, cough with expectoration 2 years, and from the last 1 month he developed 2 new symptoms: facial puffiness and edema feet. So again, when I am discussing with you, actually you have to discuss this when the present with me, but some student told that it will be little bit tedious for you. So when I am reading the chief complaints, आपके दिमाग में कुछ ना कुछ चलना चाहिए कि ये क्यों है, क्योंकि अगर आप ऐसे अभी से सोचने शुरू करोगे कि ब्रेथलेस हो गई, उसके बाद काफी फ्लक्चुएशन हो गया, 2 साल से चल रहा है, और सडनली आपको 1 महीने से फेशियल पफिनेस हो गई है, पीरियडिमा हो गया है? आपके दिमाग में आनी चाहिए ये बात, क्यों हो रहा है, क्या होता है? The breathless was, of course, was 2 years, the last 2 years. It was gradual and short and progressive. It was more on the exertion, and it's used to be relieved by rest or some medications. Or there's no history of orthopnea or occasional nocturnal dyspnea. The cough was scanty, and occasionally the sputum was copious sputum, sometimes scanty, sometimes copious, and sometimes mucoid, or which turn out to be mucopurulent and used to be respond to the antibiotics. Patient never told that it was never foul smelling. Foul smelling means due to there was no anaerobic infection. There is no moptisis, no blood, it was never blood stains, sputum, no postural or diurnal variations. So kappa associated with the scanty, very copious secretions, mucoid, mucopurulent, responding to antibiotics, never foul smelling, no hemopsis, no variation, postural or diurnal variation. For the last 1 month, the patient started having the facial puffiness and edema feet. But otherwise, there is no history of fever, no history of wheezing, no history of chest pain, hemoptysis, decreased urine output, and altered mental status. You should also say, "ए मैंने क्यों बोला है सारी चीजें?" ठीक है? In past history, this is very important. Past history, there was patient gave the history of pulmonary tuberculosis, which was AFP positive 20 years back. And he took the treatment very religiously, full treatment, it was complete. He was not a diabetic, not asthmatic, or any cardiac ailments, no history of exposure to occupational hazards, no history of any surgical procedure in the past, no history of trauma. Patient was non-smoker, was occasionally alcoholic. The appetite was okay. It was lost, but however, there was no loss of weight. Patient had normal sleep, all bladder habits were okay. History, there's no history of tuberculosis in the family. Treatment, it's very important. Treated for tuberculosis 20 years back, and on and off bronchodilators for the last 2 years. On examination, he is found to be conscious, oriented time and space. He was a little bit tachypneic. He was afebrile. You see, many times when you are describing your finding, आप ये बोल देते हो afebrile है patient. टेम्परेचर बताना चाहिए आपको. आपको पूछते हैं आपने कैसे क्यों कह रहे हो afebrile? मैंने टच करके देखा है. आप ये बोलते हो. मैंने टच करके देखा है. देखो आपके हाथ में कोई टेम्परेचर के सेंसर नहीं लगे हुए, ठीक है, क्योंकि यू आर कंपेयरिंग योर टेम्परेचर विद द पेशेंट. सो afebrile नहीं टेम्परेचर बताना है. BMI was on the lower side. The patient was not paler, no jaundice, but he has got clubbing on the hands as well as the foot at the grade 3, and he has got pitting edema. Okay, edema he has got. Now go on noting edema क्यों होएगा अभी, क्यों हुआ है. Vitals are okay, 90 per minute, sinus rhythm. The pulse was normal, volume character, this was normal. Okay. Blood pressure was okay, respiratory was little high, and it was abdominothoracic respiratory situation. See here, jugular venous pressure was raised. It was raised. The findings are very important in this fibrosis. There is a flattening of the chest on the left side, flattening. Okay, that means the intercostal spaces were narrowed. Okay. The trachea appears on inspection to the left side. Obviously, one can see epipetalus was not visualized. Accessory muscles were working like ali nasi. This is very important finding. Examiners are very fond of this finding. The drooping of the shoulder on the left side. See, this is the drooping of the shoulder. And you can see the scapula become prominent on the left side. This is the back of the patient. And this vertebral border, middle border, has shifted because the left chest is contracted, narrowed, retracted. So just to show the difference, this is a long line, this is a short line. आपको बनाने की जरूरत नहीं एग्जामिनेशन में, सर आपको समझाने के लिए बनाएंगे, ठीक है? This is drooping of the shoulders. See, okay, ये ऐसे होना चाहिए. So left intraclavicular hauling present, respiratory movements appear to diminish on the left hemithorax. Vertebral order आप बता दिया मैंने आपको. Inspiratory retraction of the lower interspace on the left side. There's no scars, no sinus, no dilated veins. Scars means there was no cold abscess. On palpation, it was found that trachea was confirmed to be shifted to the left side. Apex beat again could not be localized. There was diminished movement on the interior posterior upper thoracic movement on the left side. All chest. Here मैं आपको जहां कोई एरिया नहीं बताया, infrascapular सारी चेस्ट में ही नहीं था. There was no tenderness, no lymph node. Vocal parameters, note it. In the case of left hemithorax, more so in the infraclavicular area on the left side. Infraclavicular area on the left side. Percussion. It was impaired all over the left hemithorax except some patchy areas of resonance. Note it. Right hemithorax में आपने लाल भी बनाया हुआ है. It was resonant. आपको बोला एग्जामिनेशन पूरा करना चाहिए आप. In chest, it's a 2 plus 2 is equal to 4. You have to pick the findings from the history examination और उसको एक जगह इकट्ठे करके उसका डायग्राम बना. Auscultation. There was a bronchial breathing, whispering peculiarity, and bronchophony present in the left infraclavicular, suprascapular, interscapular. Rest areas are vesical breath sounds. अभी आप कहोगे कि ये ट्राइड तो है, अब ये क्यों हो गई bronchial breathing? ये ट्राइड कहां से आया? I will show you in the next one or slides. Right hemithorax have bronchovesical breath sounds on the right side. So most findings on the left side. On auscultation, again, there is inspiratory expiratory coarse crackle present in the memory and all over posterior part of the left hemithorax, except suprascapular area. There was no rhonchi, no pleura. Now again, जहां आपको point focus on this serious examination. वो sounds like, but P2 was loud. Here is the point. जो puffiness वाली थी ना, edema. ये पता है. There was no organomegaly, no hepatomegaly, splenomegaly, no flappy tremors. Okay. Flappy tremors means there is no CO2 retention. So what are the diagnoses we have made on finding? There are fibrosis of the left lung. The history is the post-work. This is again the pathology fibrosis. Anatomy left lung. पूरी lung पे finding थी. And we know the history post-work equally. Now, why he has got puffiness and edema? That means these fibrosis can lead to the formation or development of the corpus. Okay, when there is a corporeal हो सकता है P2 load हो तो सिर्फ P2 load हो, JBP भी raised है, ठीक है, puffiness भी है, edema भी है, that means it has decompensated. जैसे liver cirrhosis है, as such कुछ नहीं होता liver cirrhosis, जब ascites हो जाए, become liver cirrhosis with ascites, or you can say the liver cirrhosis decompensated. मैं बता रहा हूँ आपको जी bronchial विधि क्यों थी वहां पे. This is because the trachea was shifted. So we cannot say this is due to the consolidation. Bronchial विधि bronchophony. You see the mediastinum is shifted and it has become epizematus. That's why it was resonant. This lung has inflated. It's almost gone on the other side also. See, it has gone to the other side. That's why the apical impulse was also could not be located. See, the ribs were narrowed, the spaces were narrowed as compared to this side. On further CT scan, there were more findings. जो आपने वहां पिकअप नहीं कर okay, cavity was. So ECG was showing P2 was P wave prominent. That's made pulmonary was people. Echocardiogram was done. There was evidence of pulmonary hypertension, right ventricular hypertrophy, and right atrial dilatation. This is the corpus middle. Okay. केवल कॉर्पोरल मिल की डेफिनेशन आपसे पूछते हैं, पता नहीं बहुत लोग बताते नहीं है. It is the dilatation of the right side of the heart due to the malfunction of the lungs, chest bellows, and dust respiratory drive. The hallmark is pulmonary hypertension, and there should be the absence of congenital heart disease and left ventricle disease. This is the definition. The EVG was done. The pH was 70 millimeter of mercury. Okay. Other bicarbonate pH was all normal. So the final diagnosis, lung fibrosis with cavitation also. We have seen on the CT scan. Cavitation भी है, जहाँ आपका फाइब्रोकैविटरी भी बोल सकते हो, फाइब्रोकैविटरी, okay, which is due to the result of the tuberculosis. Corpuscle decompensated. You can see the emphysema. You have seen the emphysema on the left side, and on examination also we have seen that there was right hemithorax was resonant. So there was emphysema, which was compensatory, of course, compensatory emphysema. So this was the final diagnosis. The treatment, because these patients, their cough reflex is very poor, and left lung generally harboring some bacteria. This will become the septic tank. So patient will always need some antibiotic off and on. It will have some mucoid, then become purulent, mucopurulent. Okay, diuretics because the decompensated. Domiciliary oxygen. Patient PO2 was 70 millimeter of mercury. So that means this patient did not need any domiciliary oxygen therapy because a domiciliary it should be 60 millimeter of mercury. That's the definition of the respiratory failure. Because there is some cavitation, some bronchitis, some fibrosis there. It hasn't seen the bronchitis when they are having breathlessness. They respond to small dose of steroids for few days, maybe 5 days. Okay, so this treatment is all supportive. This fibrosis cannot be reversed. This patient needs only supportive treatment. Okay, and you can have 2 minutes rest, and in the meantime मैं slide ही कर लेता हूँ. Then we will go to the collapse of the. We discuss the collapse of the lung. Have 2 minutes break. क्वेश्चन लिख लो, कोई पूछना है तो. ये तीनों केस जो कंसोलिडेशन, फाइब्रोसिस, मैंने एक आपके साथ प्लूरल फ्यूजन डिस्कस किया था, यही पेशेंट आपको मिलते हैं. ये 3-4 पेशेंट्स होते हैं. अगर आप प्रेजेंट करते हैं तो ज्यादा अच्छा होता है. एनीहाउ आई ट्राई टू मेक वेरी सिंप्लीफाइड फॉर यू. Should we start next? Let us start. It's the collapse of the lung. You can see that here I have not started from the history of present illness, complaints, and so on. I started from the X-ray. First, you should understand what is collapse. You see, this is the collapse of the right lower lobe. Okay. आपको जहां कोई फाइंडिंग नहीं मिलती, कुछ नहीं है, ये ऐसे क्यों बनता है ट्रायंगुलर? बिकॉज द राइट लोअर लोब is anchored with the diaphragm with the inferior pulmonary ligament. तो जब ये कोलैप्स होती है तो इट्स लाइक हिंज लाइक, जैसे दरवाजा खुलता है दीवार के साथ लग जाता है. दिस आल्सो व्हेन कोलैप्सेस इट गोज टू द posterior paravertebral gutter. So आपको ज्यादा फाइंडिंग मिलेगी ही नहीं. Even diaphragm is not raised because this right lobe or left lobe is anchored with the diaphragm with the inferior pulmonary ligament. ठीक है. Similarly, on the left side, you can see left side. आपको डायग्रामेटिकली समझाया है दोबारा. ठीक है. ये क्या फाइंडिंग है? कोई फाइंडिंग नहीं है आपको मिले. ठीक है. This is the right lobe. Yes, is some finding, and you can see here the diaphragm is it. Now you can understand when there is a collapse of the lower lobes, there is no raising of the diaphragm because it is anchored right lower lobes to the diaphragm with the inferior pulmonary ligament. At the upper lobe, there is a volume loss and it is raised. Diaphragm is raised, and this has become upper and medially, and it's just touching the trachea. It has gone towards the trachea. That's why you can have some finding here. Otherwise, इसमें finding ढूंढना it's very difficult. जो कई बार आपको कई बार एग्जामिनर टीचर बोलते हैं ये है, इसमें कोलैप्स है, वो कोलैप्स प्योर नहीं होता, वो कंसोलिडेशन होती है. वो भी आप डायग्नोज क्लिनिकली नहीं कर सकते, जैसे मैंने आपको बोला पहले. और क्लिनिकली तीनों डायग्नोज नहीं कर सकते. ऑन सीटी स्कैन यस कर सकते हो. ठीक है. This is the total collapse. Here you can say that trachea shifted is of thoracic. Okay. I hope you have understood my submission why I have started with the X-ray. Now, let us come to the history. These patients usually with the pure, not cortical consolidation. Generally, they are not coming with the history. If there is some subtle history, very minor, which can be ignored easily, they are generally diagnosed on the chest scagogram when patient comes for some other purpose, maybe for operation of the hernia or some other operation, and आप X-ray कर देते हो, then you can find, हाँ देखो इसमें कोलैप्स भी आ रहा है, देन जो स्टार्ट एंड ब्रोंकोस्कोपी करो, ये करो, वो करो, ये करो, ठीक है. सो देयर इज सटल हिस्ट्री on examination. Now I made a chart for you. Again, inspection, palpation, percussion, and auscultation. In the right lower lobe, inspection, kappa finding आपने देखी कुछ नहीं मिल रही. I'll show you the X-ray. Again, palpation is subtle, vocal parameters normal, trachea not shifted, okay, and it is the right lower lobe collapse, okay. Percussion resonant or hyporesonant because the lung is expanded, okay, resonant. Diaphragm is not raised. Again, कोई ज्यादा फाइंडिंग नहीं है मिल रही है आपको. ऑस्कल्टेशन ब्रेथ साउंड भी नॉर्मल है, वेसिकुलर है, नोएडेड साउंड. सो राइट लोअर लोब पे आपको फाइंडिंग मिलेगी ही नहीं कोई. तो इतनी जो थोड़ा सा आपको पीछे से पोस्टीरियर गटर में वर्टिब्रा के पास पड़ा हुआ है लंग, क्या बताएगा, कुछ भी नहीं बताओगे, जबरदस्ती बनाते रहोगे आप एग्जामिन में यही करते हो, एक्सरे देख लेते हो क्योंकि उस हिसाब से फाइंडिंग बनाते रहते हो. ऐसे नहीं करना है, क्योंकि आज कंसोलिडेशन है, पेशेंट एडमिट हुआ है, आपके दोस्त इंटर्न होते हैं वहां बैठे, वो फाइल पे देख लेते हैं हाँ भी कंसोलिडेशन राइट लोअर लोब है या कंसोलिडेशन राइट लंग है. और जिस दिन 4 दिन बाद 5 दिन एग्जामिनेशन होता है, आपको पता ही नहीं है, वहां तो प्लूरल फीचर भी बन चुका है, आप वही फाइंडिंग बनाते रहते हो सेम जो आपने देख ली है. तो आप अगर आप एक्सरे देख के बनाओगे, आप कोई ना कोई फाइंडिंग बना ही दोगे. आप बता दो कि राइट लोअर लंग में, सॉरी पोस्टीरियर में पूरी फाइंडिंग बना दोगे आप. अगर एक्सरे देखे बिना बनाओगे तो आपको यही फाइंडिंग मिलेगी जो मैंने आपको बताई. Now the right upper lobe collapse I have showed you. Again, there is subtle changes. Maybe infrapallicular retraction was there. Can be detected. Here the trachea shifted to the same side. Okay, and vocal parameters increased. I will tell you why vocal parameters increased when I will discuss those condition. The percussion dull to impaired in the infraclavicular area on the right side. Okay, and diaphragm may be raised, which I told you, because the upper lobe can be raised and lower lobe not raised. Auscultation breath sound increased because trachea is shifted, and bronchial breathing it can be infraclavicular area. This is not due to anything, to direct transmission from the trachea, क्योंकि जो right upper lobe है वो जाके trachea के साथ चिपक गई है. This is so from the trachea there is a direct transmission of white noise. जो ट्रेकिया में नॉइज होती है साउंड्स, उसको वाइट नॉइज बोलते हैं, जिसके ब्रोंकियल ब्रीदिंग भी आप प्रैक्टिस करनी है तो आप ट्रेकिया में रखते हो. सो देयर इज अ डायरेक्ट ट्रांसमिशन फ्रॉम द ट्रेकिया, but there is no added sounds. Now total lung collapse, of course chest will be detected, trachea shift to the same side, right side, movement decreased. On palpation, trachea shifted same side, vocal parameter decreased, absent, apex reed displaced. On percussion, and on auscultation, breath sounds intensity decreased or absent. Vesical breathing. On bronchial breath sounds can be present in the infraradial area because due to the shifting of the That's all. So we have discussed the consolidation. Okay. Then fibrosis and then collapse. So on collapse, कई बार एग्जामिनर बोलते हैं कोलैप्स है क्या, कोलैप्स डिस्कस, आप बोलो तो कोलैप्स, प्योर कोलैप्स हम डिस्कस आप डायग्नोज नहीं कर पाते, एग्जामिनर को भी नहीं पता होता है, ठीक है, आप नहीं डिस्कस कर पाओगे, आपको जो बताना पड़ेगा, ये डिस्कस नहीं आप कर सकते, सॉरी, डायग्नोज नहीं कर सकते. So let us do the question area. Questions? If you want any question. Increased मतलब increased क्या है भाई, क्या increased, कौन सरकार, इंक्रीज किस चीज को बोल रहे हो, अब क्या बताओ, जरा पूरा लिख दो ना मेरे को. इंक्रीज मतलब क्या है, कोई बना नहीं ना, वोकल फ्रिक्वेंसी इंक्रीज क्या, इसमें क्या खास बात क्या है, कि कहाँ पे मतलब किस केस में बात कर रहे हो, क्या रेज्ड बोलना चाहिए, लेफ्ट लंग, कहाँ मैंने इंक्रीज तो राइट अपर लो में बोल रहा था मैंने, दैट इज ड्यू टू डायरेक्ट जेस, दैट इज अगेन ड्यू टू, जैसे ब्रोंकल भी ने गाई थी ना, दैट इज ड्यू टू डायरेक्ट transmission from the trachea. That's why the vocal parameter is increased. Okay, the direct transmission. I haven't understood. What do you want to ask? Again, he asked. Okay, sir. Okay. Any other question? और क्वेश्चन बोलो भाई, क्योंकि वहां से डायरेक्ट ट्रांसमिशन हो रही है, आप बोले हो 1 2 3, 1 2 3 आएगा वहां पर. पल्मोनले, what do you want to ask? Go to pulmonale. What do you want to ask? Pulmonale भाई, कॉर्पल मिले, क्या पूछना चाहते हो? है परनाती डेफिनेशन. ओके 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 ओके, राइट राइट राइट. पल्मोनल नहीं, कॉर पल्मोनल, जो आपको मैं डेफिनेशन अभी बताने वाला हूं, जहां तक आप लिख लो, ये आपको डेफिनेशन कहीं भी नहीं मिलेगी, ये मैं ही बता सकता हूं, ये डेफिनेशन आपको कहीं नहीं मिलेगी, अभी लिख लो. ओके, द कॉर पल्मोनल इज dilation of the right ventricle, okay, due to, मैं आराम नाम से बोल रहा हूं, लिख लो, due to the malfunctioning of the lungs. अब मैं आपको जो बोलूं, उसमें फाइब्रोसिस भी होती है, ये अपना इंटरस्टिशियल फाइब्रोसिस होती है, कुछ और होता है, तो उसमें बहुत है, दैट्स वाई मैंने यूज कर लिया माल फंक्शनिंग ऑफ द लंग्स, कॉमा चेस्ट वेलोस, दैट भी काइफोस्कुलोसिस भी हो सकता है, एंड रेस्पिरेटरी ड्राइव. Why I am a respiratory drive? Because of the sleep apnea syndrome, the respiratory drive is very poor, and there is a continuous hypoxemia during daytime also. That's why the complement hypoxemia की वजह से होता है ना, vasoconstriction हो जाती है, vasoconstriction से permeable hypertension हो जाती है, ठीक है. Again I am repeating. So इट इज द डायलेटेशन। आप हाइपरट्रॉफी भी बोलते हो, हाइपरट्रॉफी नहीं होती है। आपको कोई बोलेगा हाइपरट्रॉफी, हाइपोट्रोफी इसकी कॉम्प्लिकेशन हो जाती है, बिकॉज कॉर्परमिल कैन बी एक्यूट, कैन बी क्रॉनिक। अक्यूट जैसे थ्रोम्बो एम्बोलिज्म होता है, उसमें एकदम डायलिटेशन हो जाती है, वहां हाइपरट्रॉफी कैसे हो जाएगी? हाइपरट्रॉफी के लिए तो कई महीने साल चाहिए, ठीक है। सो दिस इज द डायलिटेशन ऑफ द राइट साइड ऑफ द हार्ट ड्यू टू द माल फंक्शनिंग ऑफ द लंग्स, कॉमा चेस्ट बेलोस, कुछ भी हो सकता है, एंड रेस्पिरेटरी ड्राइव। रेस्पिरेटरी ड्राइव आपको मैंने बता दी, जैसे स्लीप एपनिया सिंड्रोम है, रेस्पिरेटरी ड्राइव किसी वजह से भी हो सकती है। रेस्पिरेटरी ड्राइव जिसको बैठ कर हाइपोक्सीमिया, प्रॉब्लम होता है हाइपोक्सीमिया की वजह से है। द कांस्टेंट हाइपोक्सीमिया, द कंटिन्यूस हाइपोक्सीमिया causes the vasoconstriction in the lungs which lead to the pulmonary hypertension। अभी खत्म, डेफिनेशन खत्म नहीं हुई है, अभी आपको मैंने एक लाइन ही बताई है। So it is the dilatation of the right side of the heart due to the malfunction of the lungs, comma chest bellows and respiratory, okay, full stop। The hallmark is pulmonary hypertension। तो pulmonary hypertension डेवलप होगी, full stop। There should be absence of congenital heart disease, क्योंकि congenital heart disease भी कर सकती है pulmonary hypertension। So there should be absence of congenital heart disease and left ventricular disease। लेफ्ट वेंट्रिकल डिजीज जैसे हार्ट फेलियर पूरा कर देता है, congestive फेलियर, pulmonary hypertension डेवलप हो जाती है। So there should be absence of congenital heart disease and left ventricular disease। So this is the complete definition. Again, I am repeating, you can write again. It is the corpuscle is the dilatation of the right side of the heart due to the malfunction of the lungs, comma chest valves and respiratory drive, full stop। The hallmark is pulmonary hypertension, full stop। There should be absence of congenital heart disease and left ventricular disease। This is the complete definition. This is the corpuscle। जब ये आप उसके बाद आगे स्टेज में हार्ट फेलियर हो जाता है, कॉर्पनम इज नॉट द हार्ट फेलियर, राइट हार्ट फेलियर। आपको बहुत कई भी कर बताएंगे द राइट हार्ट फेलियर, नो, इज द राइट वेंट्रिकुलर डायलेटेशन, नॉट हार्ट फेलियर। हार्ट फेलियर तो उसकी कॉम्प्लिकेशन है, तब हम उसको कंपनसेटेड डीकंपनसेटेड बोलते हैं। आप जहां कैसे कंपनसेटेड कॉर्पनम, डीकंपनसेटेड कॉर्पनम, ठीक है। इट इज कंपनसेटेड, मैंने जो बताया आपको। जब इसको आगे स्टेज चली जाएगी और हो जाएगा आगे, फिर जो पफिनेस ऑफ फेस, पेडोडीमा, जेबीपी रेज्ड, असाइटिस भी हो जाती है कई बार। तो दैट इज डीकंपनसेटेड राइट हार्ट फेलियर, डीकंपनसेटेड कॉर्पनम। chronic corpus in thromboembolism it is acute corpus। सो आप कई बार हाइपरट्रॉफी भी बोलते हैं, हार्ट फेलियर बोलते हो, गलत बोलते हैं आपको, ठीक है जी। डेफिनेशन आपको कहीं नहीं मिलेगी, मेरी जो किताब उसी में मिलेगी आपको, और कहीं नहीं मिलेगी। और कुछ क्वेश्चन पूछना है तो कैन आस्क अदर क्वेश्चन। देखो, तो जहां तो आपको कुछ समझ नहीं लगी, जहां आपको सारा कुछ समझ लग गया है, और भी पूछो क्वेश्चन। जहां तक मेरे को लगता है कि आप ना छोड़ के इधर उधर हो जाते हो, लगता है अटेंडेंस लगा के ना, ज्वाइन करके कुछ तो रहे नहीं कुछ भी। भाई बुकल फ्रेम टेस्ट की तो बता दिया भैया, किस में, राइट अपर लोब में, किस में, किस में पूछ रहे हो आप? यस, वो तो बता तो दिया मैंने को, दिस इज ड्यू टू द डायरेक्ट ट्रांसमिशन बताया तो था अभी, ये स्लाइड भी आपके सामने ही है। इट इज ड्यू टू द डायरेक्ट ट्रांसमिशन फ्रॉम द ट्रेकिया टू दैट एरिया। ये वैसे ही नहीं होती, ये कंसोलिडेशन नहीं है, डायरेक्ट ट्रांसमिशन। That way the bronchial breathing, systolic, bronchopnea can be present. The same reason, जहाँ bronchial breathing होती है, vocal pendulum की होती है। Sometime कभी मेरे को पता नहीं, जब या मिलोगे तो आपको मैं कभी लंग साउंड पढ़ा सकता हूँ। लंग साउंड की क्या होता है, फिर आपको ज्यादा समझ लगेगी, क्योंकि वो जनरली वी टीच टू द डीएम स्टूडेंट, एमडी वाले भी नहीं इतना जान पाते, डीएम वालों को तो पता ही होना चाहिए। आपको कोई नहीं पूछ रहा, क्योंकि एग्जामिनर को भी नहीं पता होता जी, तो डोंट वरी अबाउट इट। और क्वेश्चन, एनी अदर क्वेश्चन? नहीं, फिर बंद करते हैं, बोलो जल्दी जल्दी पूछो कोई और। लो कोलैप्स, व्हाट इज में लो कोलैप्स? क्या मतलब पूछ रहे हो भाई? लो कोलैप्स ऐसे मेरे को ना, ऐसे ना लिखो लो कोलैप्स, आप पूरा लिखो ना, फिर हम ये पूछना चाहते हैं लो कोलैप्स मतलब। किसने लिखा है लो कोलैप्स, पता नहीं है। लो कोलैप्स तो मतलब नहीं समझ लगी। लोब लोब होती है, जैसे राइट साइड में 3 लोब होती है, लेफ्ट साइड में 2 लोब होती है। लिंगुलर इज लोब इज आल्सो पार्ट ऑफ द अपर लोब। इसका तो मेरे को समझ लगी, लो कोलैप्स किसी ने क्वेरी कही है, मेरे को समझ लगी आप क्या कहना चाहते हो। आप लो कोलैप्स बारे क्या पूछना चाहते हो आप? और क्वेश्चन नहीं है तो बंद करें फिर। ओके ओके, बेस्ट ऑफ लक एंड स्टे सेफ, अपना ख्याल रखो। ओके।